directors here today to give you some welcoming remarks. And so I'd like to introduce you to Ian Rick-John. Ian is the chair of our policy committee here on the CPEN board, and so really is sort of the leadership of our strategy around the policy issues that we tackle as an organization, how we work with communities to advance policy change. Ian is an adjunct professor at the Department of Health Sciences at California State University, East Bay. He is also a consultant for the Asian and Pacific Islander American Health Forum, which is a national health justice organization focused on improving the health of Asian Americans, Native Hawaiians, and Pacific Islanders living in the United States and its territories. He previously served there as a senior policy strategist, and he's also served as a policy analyst for the Office of Minority Health and Health Disparities at the Maryland Department of Health, as well as a research consultant for the Loma Linda University School of Public Health. Ian has an MPH in epidemiology from the Loma Linda University School of Public Health and a JD from the University of Maryland School of Law. We are just so grateful to have Ian and everything that he brings on our board of directors at CPEN. And so I want to thank Ian, and I want to turn it over to him to offer his opening remarks to all of you. Ian, take it away.
Thank you so much, Karen, and thank you all for being here this morning. On behalf of the CPEN board, I want to welcome you to day 2 of the conference. It's great to see so many of you here virtually. It looks like we've got over 150 and growing right now. So thank you all for joining this morning and being here for the conference. I was teaching a class yesterday, so I was only able to join a portion of the workshop on telehealth yesterday, but I'm glad that I can be here this morning to be with you all today. I just want to tell you a little bit about my first experience with CPEN. So back in 2013, I was a new policy analyst. I had just started working with the Asian and Pacific Islander American Health Forum. We had recently moved to the Bay Area, in the San Francisco Bay Area in 2010 from Maryland. And I had just gotten a job in 2013 with the Health Forum. And that's when I first was introduced to the Health Forum, to CPEN. At that time, the president and CEO of the Health Forum, Kathy Ko-Chin, was a board member of CPEN, and she asked me to come to one of the board meetings, the CPEN board meetings, to participate in a policy discussion. And it was then that I was really first introduced just to the breadth of work that CPEN was involved with. And I was so impressed, by CPEN's work then. And over the past 8 years, I've had the opportunity to work with staff, in multiple areas in different capacities, and have really been, impressed by the work of CPEN and the organization and the real impact that this organization has in California. And now I'm honored to have the opportunity to serve as a board member. So I think, as we all know, issues of equity have really been highlighted in the past year due to COVID. And I really believe that CPEN is the right organization to help lead us through these times, as they always have, with a laser focus on policy advocacy and working and supporting communities. Over the past year, the CPEN board has been very engaged in conversations about how we more fully embrace our mission of advancing health equity in a COVID world, how to continue to support communities of color, and also thinking about how do we really work toward dismantling structural racism. So we hope that, I'm glad that you're all here today. I hope you had, some of you were able to join yesterday for many of the different sessions. I hope this conference really provides you with some time for reflection, some additional tools to use in your work, and also an opportunity to think about new ways that we can partner together to mobilize for health equity. Obviously, in this virtual kind of situation where it's not as easy to network and talk, but there's still opportunities for us to share experiences, share what we're doing, and I hope this conference provides that forum to think about, to hear about what different people are doing around health equity, think about what each of us are doing in order to advance health equity, and how we can continue to work together and partner together to move forward. So I just want to thank Karen again for her leadership, the amazing staff of CPEN. It's just always a great opportunity to work with the great staff at CPEN for all their efforts, especially organizing this conference. Under these circumstances, we all would love to be in person, but it's nice to still be able to meet virtually. And I want to thank the staff for putting on all the work to put on this conference. I'm sure many of you are excited about today's opening session, just as I am, somebody that really likes data and enjoys talking about data. So I'm excited for this upcoming session with Carrie and Ninez. So with that, I'll turn it back over to Karen, and thank you all again for being here today.
Great. Thank you so much, Ian, both for those remarks and for your leadership on behalf of CPEN. We very much appreciate you and all of the work that you do with us and with our communities across the country. So now I'm going to turn it over to one of our amazing staff members, Carolina Valle, who's going to give us an overview of the day ahead. Carolina?
Great. Yeah. Thank you all so much for joining, and great to see such great attendance. So I'm going to go over our 4 workshops today. As Ian mentioned, we're going to have an awesome plenary session where we're going to talk about health equity and data. But before we transition to that, I'm going to give you a preview of the 4 sessions that you can choose to join after the plenary session. So the first session is Blooming in Our Visions, which is really going to focus on the role of radical imagination in dismantling harmful systems. The second workshop that you can choose from is focused on centering equity and payment and delivery reform. And that's really going to look at how California can address health disparities through payment and delivery reform in the coming years. The third workshop is called Connecting Our Movements, Criminal Justice is Health Justice. And that's really going to look at how California can reduce law enforcement involvement and invest in community programs and solutions. And then lastly, we have a workshop on effective public health communication during the COVID-19 pandemic. And that's really going to look at, as the name suggests, the importance of population-specific communications and what strategies have worked thus far. So you've got 4 workshops you can choose from, and CPEN staff will drop the full program agenda in the chat box for you so you can take a look. When you navigate to the workshop, you can click on Agenda in the left-hand sidebar and then select the title of your preferred workshop. After the workshops, you can join us at 12:30 for office data hours. And we're going to have 2 data experts from CHIS at UCLA joining us, which is one of actually the preeminent data clearinghouses here in California. So join us at 12:30 after the workshops and bring your questions and curiosity about how you can use data in your work. But before we do all that, I'm going to pass it over to our amazing Senior Policy Director, Carrie Sanders, who will introduce our plenary.
Thank you, Carolina. Hi, everyone, and welcome to today's plenary, Understanding Health Equity. My name is Carrie Sanders. I'm Senior Policy Director with CPEN. I've been with CPEN for 12 years now, through many iterations of conferences. So for this particular plenary, as we know, understanding and using data is integral to advancing health equity. As we're seeing with COVID-19 and other issues more broadly, numbers tell a story. Without them, we don't have the full picture of what's happening and how to address problems. But understanding data and related terminology can be hard and intimidating. It's hard to know how to interpret what we're reading and how to ensure we're telling a complete story. Fortunately, we have an expert on data and health equity with us today. I'm so excited to introduce today's plenary speaker and former CPEN board member, Dr. Ninez Ponce. Dr. Ponce is professor in the UCLA Fielding School of Public Health and director of its Center for Health Policy Research. She leads the California Health Interview Survey, the nation's largest state health survey recognized as a national model for data collection on race, ethnicity, sexual orientation, and gender identity, and immigrant health. Her research contributes to the elimination of racial, ethnic, social disparities in health. She serves on several key boards and committees, including the National Center for Health Statistics and National Quality Forum, where her expertise is focused on setting guidance for health systems in the measurement and use of race, ethnicity, and social determinants of health as tools to monitor health equity. She's received numerous awards from community organizations recognizing her work in community engaged research. I think we'll hear a little bit more about that today, and has received awards for her contributions to population health measurement, to inform public policies. Dr. Ponce champions better data, especially on race, ethnicity, social determinants of health. And with that, it's my pleasure to introduce Dr. Ponce and turn it over to her. Thank you.
Thanks so much, Carrie, and thank you, Karen, and thank you, Ian. Welcome, everyone. I see we're close to 200, so I hope everyone can hear me. I would like to request the person who is helping me with the slides, is that be put up, please? So, Carrie.
Are we still not, we're not seeing the slides? Let me make sure we get those up for you.
Okay, thank you.
All right, looks like they're up. Sorry about that.
No worries. Thank you. Without data, what would I talk about, right? So, so thanks again. Today, I'm going to talk about understanding health equity, especially with regards to the importance of data. So, next slide, please. And I'm from the UCLA Center for Health Policy Research. So, next slide, please. And then, so I'll talk about 10 minutes, just briefly, and touch on major issues of inclusion, invisibility, why data is important for health equity, and then hand it off to the CPEN staff to go over the CPEN landscape brief. Then I'll come back on and talk about some COVID-19 dashboards and data tools, and then how these tools could inform the COVID response and how they can be improved, and then we'll end with a Q&A. Next slide, please. This is not an audience to tell everyone about what the difference between equality and equity, but let's just start with that. Health equity is about the opportunity to attain their full health potential, and that no one is disadvantaged from achieving their potential. And what's important is that what we're observing in terms of inequities is because of inequities in opportunities in social position or socially determined circumstances. And again, the fundamental difference that equality, which is giving everybody equal amounts of a resource of opportunities, is not the same as equity, which is to give people what they need. Next slide. And my role is measurement, and measurement is key to achieving health equity. And it's this, it's the building of the infrastructure that would inform programs, but also would inform policies. So how to inform policymakers on how to prioritize resources, how to prioritize funding of programs, vaccine allocations, which is top of our mind, and also to ensure that there's that the allocation is, in case of vaccines, is as quick, as effective, and achieves the goals of ensuring that we undo some of the inequities that led us to the inequities that we're seeing right now in COVID-19. So measurement is key. Next slide. So going on COVID-19 race ethnicity data. Next slide, please. Back in July 2020, New York Times forth an article on the fullest look yet at the racial inequity of coronavirus. And at that time, the headlines were on the inequities of cases for Blacks and Latinos as compared to whites in the general population. And this was because this was the best available data at that time. Next slide. But the question is then, is this fullest look inclusive? Next slide. And this is California data, and this is data from the California Department of Public Health. And this then looks at racial and ethnic case rates per 100,000. So back in July 2020, just where the red arrow is, that we start to see that there are already high case rates for the Hispanic population, the Latino population, but also for the Native Hawaiian and Pacific Islander population. And at that time, there were already some stories about the inequities that were the toll on the Native Hawaiian Pacific Islander population. But reporters would come to me and ask, is this a small numbers problem? Do we really believe that this is happening? Even though in the Native Hawaiian Pacific Islander communities, there were already stories, there were already many funerals that people had gone to that were telling of this toll in this community. But the data at that time started to show it, but even though the data showed it, there was little attention. And then going now up to to the end of last year and to the beginning of this year, we see that the case rates continue to go up along with the Latino population, going up through, and this is in California, through subsequent months since July 2020. And we see also that we're not quite there in flattening, but compared to other racial ethnic groups, that the Latino and the Native Hawaiian Pacific Islander group, that there is this acceleration, a steeper increase of case rates for the Native Hawaiian Pacific Islander population. But in a lot of what is the headlines and what we see in terms of policy priorities neglects this population. Next slide. But our population is also invisible in the data. And I'm trying to understand what the intersections are of race, ethnicity, with sexual orientation, gender identity, and disability, that also is not visible in public-facing data. Next slide. And then there might be representation of some groups in the public-facing data, but these groups may be then hidden so that the small group insights then are lost in the larger groups. So here's an example. Next slide. This is data that is restricted, that is not publicly available, but was presented at one of the meetings with the California Department of Public Health on looking at Asian American data. And here is data for healthcare workers in California, and the deaths to case ratio, which is kind of like a case fatality ratio. It's a metric that gets at severity of COVID-19. And for healthcare workers, for the Asian population, which is the aggregate category, Asian healthcare workers do have the highest death to case ratio compared to other racial ethnic groups at 1.18%. But if you untangle that and disaggregate that, you see that the Filipinx AO population has a death to case ratio that is astronomical, 6.4%. Again, this is hidden in the aggregate data, and so there's that invisibility within a larger aggregate group. Next slide. Continuing also with another way of looking at this disproportionality. This is the proportion of populations in COVID-19 healthcare worker deaths in California. This is as of November 5th, 2020. when I was able to see this data. And this data then also shows that among the COVID-19 deaths, so that's the red bars, that 36% of COVID-19 deaths of healthcare workers are Latino. And the population, Latinos are 39%. But again, we look at Filipinos. With Filipinos, we see that 31% of healthcare worker deaths in California are Filipino, but Filipinos only make up 3% of the population. So this then gets at this disproportionality. Next slide. And this invisibility in public-facing data is a problem. It's a problem because when policies are being made very rapidly based on available evidence, then there's going to be groups that are overlooked and are going to be left behind. Next slide. This invisibility gets at invisibility of intersectionality of immigration. So race, ethnicity, and immigration, as well as occupation. And then next slide. And where the only way we can hear about this, or the evidence that is heard, is through memorials and elegies that have been put forth by community organizations. And this is an elegy of the frontline healthcare workers, Filipino descent globally. So only then to these looking at GoFundMes, looking at this organization, Affirm, looked at obituaries, looked at all the Facebook pages that were talking about the pain, the toll, and the losses. And then I think it's a shame that surveillance then is left to these memorials and elegies and not in public-facing data. Next slide. Government data. So another point of data and health equity is, are the measures really what we need? So do the measures convey the enormity of pain and loss, particularly in COVID-19, or convey on the positive side, the community assets, the cultural assets that aren't conveyed necessarily in data sets that present what's happening with the average consumer. So it's the importance of measures then and conveying what the lived experience is of a diverse population is really important in data equity. Next slide. It's a LA Times story of a family that was ravaged by COVID-19, multi-generational family. So again, data that conveys multi-generation, housing density, is that available? Next slide. So why does race matter for COVID-19? I'm focusing on race ethnicity. Because if we think about it as the susceptibility, how infectious a person is, the hospitalization, the opportunities for recovering and not dying from COVID-19, that all of these components of this kind of life history, the course of what happens with the pandemic, is associated with race, ethnicity, language, and literacy. So it's associated with age because the age distributions differ by race, ethnicity. I think there's already been some evidence that the 65 plus, you can see 65 plus is going to be predominantly the non-Latino white population. So the age distributions are different. So there's going to be a higher susceptibility by age among the non-Latino white population. There's going to be race, ethnicity differences in employment, income, and food insecurity. I think many of you know here, again, of the essential workers that are predominantly communities of color. Food insecurity, again, affecting mostly communities of color. There are going to be gender differences, immigration status and race ethnicity intertwined, and sexual orientation, gender identity, and what we'll talk about later in the second part of my presentation on the hazards of place. So where you live, the urban space and the density makes a difference in getting in having higher susceptibility. And all of these factors are also associated with higher risk of spread, of being infectious. And then the last part is once you're infected and you get hospitalized, then the question of, do you have access to care? Do you have access to care to hospitals that have oxygen, that have the equipment that can take care of you? So then the chances then of recovery once you have the virus then is all shaped by all these social conditions, by race, ethnicity, and why having data in all these pieces would be important to understand then where not only where the burden falls, but also an opportunity to for policies to be responsive on allocating resources to the different domains of this burden. And of course, now we're talking about vaccine acceptability, vaccine acceptance, and vaccination rates. Next slide. So a few metrics of disproportionate burden, because we hear that a lot, and just a really quick 101 on this, some metrics, is that the disproportionality, you could say that we've lost, 38,438, it's actually over 60,000 Black lives to COVID-19. This was back in September, but now it's over 60,000 to date. And then Black people account for 21% of COVID-19 deaths where race is known, but comprise, a smaller proportion of the population. So this proportion is if the percent of COVID cases or deaths are going to exceed the percent representation of the population. You could look at the total case or death rates per 100,000. This is really important, particularly for smaller racial ethnic groups, American Indians, Alaska Natives, Native Hawaiian Pacific Islanders, and subgroups within the larger Latino population and the larger Asian population. It's because you don't get at the sense of the toll unless you divide by the population, so a per capita rate. And so, an example here, early on, there was a hotspot of COVID-19 in Arkansas among the Marshallese. So Arkansas is currently seeing NHPI COVID-19 case rates far higher than any other race or ethnicity. And then it can also do the comparison with a referent of typically the non-Latino single race white category. And so can compare then the case or death rates per 100,000 to one referent group. And then what I'd shown earlier is a death to case ratio or case fatality ratio, again, getting at the severity of the disease and its effects on populations. And this case fatality ratio is just simply dividing deaths over cases. Attributable deaths is another metric where the share of COVID-19 deaths compared to total deaths have been seen. I just did a paper with some colleagues at UCSF where we showed that attributable deaths were highest for the Latinx population and also high for African American, the American Indian, Alaska Native, and the Asian population. And then now, as we're seeing, excess deaths in 20 is another metric where you compare the deaths for 1 year compared to the pre-pandemic year. It could be 2019 or earlier. To see that whether there are excess deaths have had a greater toll on different racial ethnic groups. So these are some examples of how to get at disproportionality that you can compare across different race ethnicities, and that They have been used, and the evidence has shown for the major racial ethnic groups that communities of color have been unduly burdened. Next slide. So, but still, you know, there's incomplete and aggregated data. Most are still not age adjusted, and age adjustment actually makes it worse for groups that tilt towards a population distribution of being younger, for example, the Latino population. And not all comply with the Office of Management and Budget race ethnicity standards of race ethnicity reporting. Many do not report multiracial categories. So if I could see all of you and had a poll and I was in class, I'd say, how many people have heard of the OMB standards? The OMB standards are, were in 1997 and required that at least 5 racial groups, American Indian, Alaska Native, Asian, Black African American, Native Hawaiian Pacific Islander, and white, and the Latino Hispanic ethnicity be collected and reported in federal data systems. When we started tracking COVID-19, there were many states that did not comply to the OMB race ethnicity standards. And then for those that do comply, small populations remain hidden in this data, as I had showed in the example on the Filipino healthcare workers in California. The Native Hawaiian Pacific Islander data is available in 21 of 50 states. And so this high need population, in some cases, we don't know where that group is lumped. Are they lumped in the other category? Sometimes we do know they're lumped with the Asian category, and sometimes in a multiracial. So again, this imprecision, this misclassification then makes it difficult to track across racial ethnic groups. Next slide. So we want to center equity in all health and societal data systems. So I went beyond not just the health systems, but if we really are to try to get at health equity and the social determinants of health, other wider data systems, employment, education, for example. So we want to go beyond the minimum guidelines. In places where there is a diverse population, where we could go into beyond minimum guidelines, and data suppression or disclosure risk mitigation is not an issue. There's the ease of access and transparency is very critical. So once you collect data, you also have to make it available. It just can't sit on the shelf. And you want to make sure that it's accessible, it's transparent. And developing measures have to go through a multiple stakeholder process, because the only way that data can be salient and relevant to communities is that if community stakeholders are there, at the design of creating these measures. I want to say that small samples is not an excuse for invisibility. We can talk about that more as I continue the conversation. And then the imperative that exploration of intersections of race, ethnicity, of SOGI, of immigration status, of SDOH, of disability, that also then has to happen. But the only way that can happen then would be to have data that is transparent. So next slide. I think this is the cue for Carrie. So why we're doing all this is that data is available to uplift marginalized communities. That's the power of data. But with the invisibility, you're not able to do that. It addresses health disparities. It addresses structural inequities. Data should address structural inequities. And because the data is a way to address the distribution of power, income, goods, and services, how they're allocated. And then lastly, again, the importance of social determinants of health. So with that, next slide, please. This is the cue for Karen and Carrie.
Great, thank you, Dr. Ponce. If you could advance to the next slide, please. Great. Oh, sorry, just getting up my notes here. So I'm really pleased to and excited to be able to share CPEN's latest data resource with you. Previously published in 2009, 2012, and 2016, CPEN's edition, this is the 4th edition of the Landscape of Opportunity. It's now available on our website, and I hope folks will take a look at it. It examines racial and ethnic disparities in health and social determinants of health. It includes data from UCLA's California Health Interview Survey and the Community Survey, along with other data sources. It was first published over 12 years ago to highlight the fact that health disparities are caused by a myriad of factors, as Dr. Ponce mentioned, that stem from historic structural racism, which make access to critical resources or block access to critical resources, such as safe neighborhoods, healthy foods, and generational wealth that are needed to achieve and maintain good health. The landscape of opportunity is organized into 4 key sections. California's diverse communities, systemic racism and health outcomes, systemic racism and healthcare delivery, and a section on COVID-19. Our staff, led by Carolina Valle, Jeffrey Coe, Susan Flores, and Aviva Prager, have done the painstaking work of sourcing the data and breaking it down into bite-sized pieces in order to tell a more complete story. So if you could advance to the next slide, and the slide after that. Great. Excuse me. California is diverse. Communities of color make up over half, 63% of California's population. The counties with the highest percentage of communities of color are Imperial, Los Angeles, and Merced. As the nation's most diverse state, California represents a wide array of communities of diverse races and ethnicities who speak many different languages. This diversity should help us to contextualize the urgent needs and opportunities before us to advance health equity. As the state moves to address longstanding health disparities and challenges, it must account for the varied and specific needs of these communities, ensuring that no one is left behind. Next slide. Despite making up the majority of the state, communities of color continue to experience and face persistent health disparities, including higher rates of asthma, diabetes, and obesity, resulting in a shorter lifespan, less wealth, and less opportunity. As this table shows, Native Hawaiian and Pacific Islanders communities experience double the rates of diabetes than white people. Black, Latinx, Asian, and multiracial communities all report higher incidence of diabetes than white people. These disparities cannot be attributed to any inherent characteristics of these communities. They're the product of structural and racist inequities that block access to resources and opportunities. Next slide. And then if you could skip to the next slide, please. A healthcare delivery system that is not grounded in racial equity will result in racial disparities. This is especially important given the current population in Medi Cal. At 80%, communities of color compose the majority of Medi Cal enrollees. The enrollee group are Latinx members who make up 57.7%. The second largest group comprises white members who make up 19.3%. And the third are Asian members who make up 11.7% of enrollees. Despite representing the majority of Medi Cal enrollees, communities of color are still more likely to be uninsured or underinsured. Moreover, crucial needs like mental health care and dental care continue to be unmet, even when health delivery systems like Medi Cal count these two benefits as part of their comprehensive coverage for adults. Next slide. And then if you could skip to the next slide. Once communities access care, utilization rates, particularly for mental health benefits in Medi Cal, is low across all demographics. However, racial disparities exist within the program. Generally managed care mental health services within the Medi Cal program are for beneficiaries with mild to moderate levels of mental illness. Nearly all racial groups utilize mental health services under their managed care plans at a lower rate than white beneficiaries. However, the lowest rate of usage within the managed care system is by Asian and Pacific Islander beneficiaries at 1.5%. In comparison, there were only 2 racial groups that exceeded white access rates from county mental health services, Black and Alaska Native or American Indian people. County mental health services are generally meant for more severe cases of mental illness. Next slide, please. And if you could skip to the next slide. So lastly, just want to focus a little bit on COVID, and we'll set up a little bit for Dr. Ponce's, the next part of her presentation. As she explained, though health disparities among communities of color existed before the COVID pandemic, the public health crisis has further exacerbated these disparities. Latinx and Native Hawaiians or other Pacific Islanders have over 3 times as many cases of COVID-19 versus their white counterparts. Black people and American Indians or Alaska Natives have nearly double the cases over white people. And although data for Asians suggests this is a lower case rate, disaggregated data that breaks out apart the diverse ethnic groups classified as Asian is not available, and contributing to the invisibility factor that Dr. Ponce described. And this is also true with deaths. Deaths due to COVID-19 reveal further disparities among communities of color, with Black, Latinx, Native Hawaiian, or Pacific Islander communities all experiencing COVID-19 deaths at higher rates. Next slide. Why are we seeing these disparities? At the start of COVID-19 stay-at-home orders in March 2020, workers with essential jobs maintaining our societal infrastructure and operations were exempted from stay-at-home orders. Often these positions put essential workers at a higher risk of contracting COVID-19, and communities of color hold the largest percentage of essential workers. The Latinx community is the largest group with frontline essential workers at 55% working in these positions. Among Black people, 48% are frontline essential workers, while 37% of Asian people are frontline essential workers. White people have the lowest percentage of frontline essential workers at 35% of the white population. Next slide, please. And these disparities go beyond health to the social determinants of health, including housing and wealth. The coronavirus pandemic has caused a significant increase in unemployment that has left families unable to pay their rent and will likely stall recovery efforts for many years to come for these populations. Next slide. So to conclude, I hope this has given you a brief, kind of quick taste of the landscape of opportunity. Thank you for your time, and I hope folks will check it out on our website. With that, I'll turn it back to Dr. Ponce.
Thanks, Carrie. The next slide, please. So I think the key part here, we've heard a lot about data equity, is one way also in terms of access is we want to minimize what we call information asymmetries, that only some groups of people understand the data and know how to get access to the data. But we also want to make sure that part of this is that there's an unequal burden of transaction costs that are related to getting more precise data. The transaction costs could be, having to make a special request, a public information request, or applying to get restricted data, which could take some time. So this also is part of this data equity equation, is the access to data. Next slide. I'm going to go a little quicker because so I'm going to go over some data tools very quickly. And we'll have this available for those of you who would like to probe more on these tools. So next slide. There's many dashboards by race ethnicity. And next slide. This is the COVID racial data tracker that's put out by the Atlantic Magazine and Boston University. It's, I think it's an excellent source of state level data of cases and death rates, and they're working on other data by race, ethnicity, for example, hospitalizations, and of course vaccinations. Next slide. Another source is American Public Media Research Lab. They focus on deaths, and they have the deaths per 100,000 data available. In the Atlanta, the previous one that you would get the actual cases and deaths. Here it's deaths per 100,000. And here again, we're seeing that Indigenous and Black African-American deaths are highest nationally. Next slide. This is a webinar for the Native Hawaiian Pacific Islander COVID-19 Data Policy Lab that we started at the UCLA Center for Health Policy Research, spurred by community groups, spurred by NHPI COVID response teams. And we have a data dashboard, and I'll show a little bit of that. Next slide. So this dashboard features Native Hawaiian specific islanders, but also includes other race ethnic groups. So this could be a good resource for you. It takes data from the COVID tracking project, from the Atlantic magazine, but we highlight the states that do report Native Hawaiian Pacific Islander data, and we've been highlighting since April of last year. So this particular screenshot looks at California. I mean, this is what I showed before, and this is the case rate, but also the death rates. If you look at the death rates, and then this orange line is Native Hawaiian Pacific Islanders, so the highest death rates in California. And then we look at the top 9 states. Like, is it just a California problem? And we look at the top 9 states, and we are seeing that it's just the leader of the pack, unfortunately, Native Hawaiian Pacific Islander population in terms of case rates in these 9 states. But we do have the data also for other racial ethnic groups. Next slide. California Health Interviews Survey. Our team members will be available, for office hours. But for those of you who do not know, the California Health Interviews Survey, or CHIS, we are the largest continuous state-based health survey in the United States. We interview more than 20,000 adults, teens, teenagers, children, and we do design the survey from the ground up with stakeholder input, and it has been used for, we collected data for governance and health system accountability, for new knowledge. We have a host of questions beyond health and health access, questions that look at food insecurity, questions that look at neighborhood safety. So a host of other factors that again could lead to opportunities. So, and we have employment, and we have occupation and industry. So I think that it's a data set that might be of use for you. We have community engagement, disaggregated data on race, ethnicity. We collect data on several Latino groups, several Asian groups, and report that. We also collect data on American Indian, Alaska Native tribal enrollment and affiliation. Since just recently, since the last 4 years, we've been collecting data. I saw in the chat SOGI, so sexual orientation, gender identity. So we've been collecting data on sexual orientation since the beginning of CHIS in 2001. Well, it's 20 years old, and we've started collecting on gender identity, which is different from gender. So gender, we do ask a question on gender, but then we do a follow-up question on the gender assigned at birth, and then the current gender identity. So that's how we get the gender identity question. And We also then ask questions, some sensitive questions, but we do it in a careful way and with a lot of preamble that we're not going to report this information to immigration officials. So we ask questions on citizenship, on green card, whether somebody's holding a green card, whether they're naturalized, and democratized data. So the data is available for researchers for public use, but we also have free web query systems. Again, I think office hours that our team can go over that, called Ask CHIS and Ask CHIS Neighborhood Edition. So Ask CHIS Neighborhood Edition is a new product, and in fact, we launched a few products today on that platform on the various vulnerability indices that are being used for vaccine allocation. So the Social Vulnerability Index, the Healthy Places Index, and the Area Deprivation Index, as well as a UCLA index that was just launched. We do try to make sure that the data is freely available, and that if there are some disclosure risks that's involved, we do have a data access center. So that was my thing. Next slide, please. I'm going to go over this very quickly. Just one of the dashboards here that's based on county. Next slide, please. Another dashboard that doesn't just look at the counties, but look at race, ethnicity, data by county, but then also has the accompanying health and social demographic indicators, again, that may have led to some of these inequities that we've been seeing in COVID-19. Next slide. This is an infographic of a COVID-19 module that we also put out in 2020. I think that the key points here are that we're seeing that 76.6%, this is again back in 2020, we had a question is, would you get the vaccine once it is available? So this is before vaccine availability, and 76.6% said that they would get it. And but differences across race, ethnicity, and differences that we're seeing where African Americans had the lowest proportion that said they would get it if it would be available. So what we're hearing now about low vaccination rates for African Americans, I think, is no surprise. Is that there were already indicators, even previous to 2020, in low vaccination rates, so that the response then, I think, should have is happening and could have happened a lot sooner to ensure that vaccine hesitancy was addressed. There also increased at home conflict during stay-at-home orders. We also got at these questions on the pain points of what people are experiencing during the pandemic that you don't necessarily see in administrative data. But looking at, was there increased conflict? Did you have reduced job hours, income? Did you have difficulty paying for basic necessities? And in looking at that question, we see that the highest proportion of Californians who had difficulty were African Americans at 23%. The next slide. Sorry, before you go to the next slide, another important piece here is on the bottom here is that we had a question on being treated unfairly. So Asians were more than 2.5 times more likely than the total population to report being treated unfairly during the pandemic. So next slide. Another dashboard, I'm not going to go over this, but for those of you who work at the county level, so we were presenting at the state level, and then there was a request that we really need to know what's going on in the counties. So this dashboard is the COVID-19 2020 module by counties. Next slide. And then this the last dashboard we just released last week on estimates on the Asian American population related to hate during COVID-19. Next slide. And this is the dashboard here where the question is, have you witnessed another Asian or Pacific Islander person being treated unfairly due to their race, ethnicity, or national origin? And the case here is that it's, if it has an asterisk, it's actually unstable. But we do see stable estimates for Chinese, Filipinos, and Japanese, Chinese, Filipinos, Koreans, and 2 or more Asians where on average, a quarter have said that they have witnessed an Asian Pacific Islander being treated unfairly, and then the differences across different racial ethnic groups, where actually the multiracial population, more than half of the multiracial Asian population witness unfair treatment to Asians or Pacific Islanders. Next slide. So I'm going to get to the policy playbook addressing inequities. And next slide. The equitable vaccine frameworks are put forth by ACEP, Advisory Committee on Immunization Practices, out of the CDC, and also the National Academy of Sciences, Engineering, and Medicine, or NASEM. And ACEP recommends that allocation strategies of COVID-19, and in quotes, should aim to both reduce existing disparities and to not create new disparities. And so this is straight out of their ACEP guidelines and ethics and values. And for NASEM, they recommend setting aside 10% of federally available vaccines to be added to the allocations so that worse off groups would otherwise be offered, proportionate to the population. So NASEM has a risk-based framework on vaccine allocation. But I also note that complementing this effort are that jurisdictions should further ensure that special efforts are made to deliver vaccine to residents of high vulnerability areas, defined as 25% highest in the state. So enter this metric of then how do you define what a vulnerability area is, what a high vulnerability area is. Next slide. So this is from an article that came out in December out of Georgetown and also University of Pennsylvania. They looked at all the states and what the vaccine allocation frameworks are. And 18 states, they found that 18 states adopted this novel proposal to use a disadvantage index to allocate vaccines. And this disadvantage index was typically in fact, in all states except for one, California, uses the social vulnerability index. So yet just over a third of all the states, but despite there's 18 states, a third of all the states, only half of the 16 states with the largest shares of disadvantaged populations where reducing inequity would be the most urgent, pursue such goals. So again, even though there are 18 states, the ones that had the largest disadvantaged population were not pursuing these goals. Next slide. So when we think about then, what these measures are, I'm going to talk about 4 measures: the area deprivation index, the social vulnerability index, which is what is being used in those 18 states except for California, the Healthy Places Index, which is what California is using, and then this UCLA index called Pre-Existing Health Vulnerability Index. Okay, I have 3 minutes left. Let's go. Next slide. The next slide, I'll just explain this. And so looking at these 4 indices, the takeaway here is that there's a host of domains of poverty, housing, employment, education, but it's only the social vulnerability index that explicitly has race, ethnicity, and language. And the pre-existing one looks at disease, looks at health conditions. Next slide. These are the elements of the Healthy Places Index. Next slide. And it also is Social Vulnerability Index, again, underscoring that it's the only one that has minority status and speaking English less than well. Next slide. So, next slide. When we look at the Healthy Places Index, this is a quick analysis that we had done at the lab, is then we looked at whether there was underrepresentation of different racial ethnic groups using the HPI. And by county, here we list the counties where there is underrepresentation, mostly for the Asian population, but also for Native Hawaiian Pacific Islander population, where we're using an HPI to target resources would underrepresent the NHPI in 17 counties, LA being one of them, and then juxtaposing that with this enormous toll on this population here in terms of cases and deaths. Next slide. This is about a concordance across the measures. Each measure is not exactly measuring everything the same. Next slide. Next slide, we can keep going. Next slide. Let's go to, no, the previous slide as I end this here, previous slide. So this, hopefully this presentation has provided some, what the tools and dashboards are, but understanding what the measurement assumptions are, and that we do need for policy recovery, that these area-based vulnerability indexes are needed and are are one way of getting at vaccine allocation quickly, but they also need to be enhanced by other indicators. For example, limited English proficiency, multi-generational households, essential workers. Next slide. And then finally, data is a tool for informing priorities, but again, number one is that it has to be salient to communities. It has to be inclusive and accessible to achieve health equity goals. So sorry if I went over time, but end of my presentation.
Great, thank you so much, Dr. Ponce. This was so informative, and I, we got several questions asking about the indices being used for COVID-19. So really great to kind of hear your breakdown of the different indices, the pros and cons, and the importance of maybe using several to tell the complete story. I think one of the questions we were hoping you could just touch on, and I realize we're kind of towards the end of time here, so I don't know if we'll have a lot of time for further questions, but how can we work to better raise up invisible groups? We see these different indices and efforts to try to tell a complete story with data that don't always tell the full story, to really show what's happening with these smaller subpopulations. We also see federally, the folks leading the Biden administration's health equity response or task force acknowledging, shockingly, that the U.S. is missing 40% of race ethnicity data on the COVID vaccination. How can we, what advice would you give to, federal, state administrations to fix these deficiencies and to ensure that this invisibility, we're addressing this?
Well, I think that, thank you. I think that the first is awareness that there is invisibility. So I think that there's not going to be any action if policymakers think that the data is good enough. So the first is then showing that this, and sometimes the OMB guidelines it's a threshold, it's a beginning, but it's by no means it's the end of accountability on data equity. So I think that that's the first piece, and And then a lot of, how data ecosystems change really is because the leaders, the people in the design phase, people who are designing and creating the data have that commitment to interrogate the data, to look even more like, are we, could we do a little bit more? Like, could we present, could we relax the suppression rules because the velocity of the virus is such that we just can't, we can't afford to, to think about the suppression rules, at this time, or is there ways that where we can have interim aggregation, say, of instead of having, some smaller groups and saying less than 11, that aggregating, say, the Southeast Asian group, or not Vietnamese, are actually enough cases and deaths to present that. So I think that kind of the collection is there. From what I'm seeing is that there is collection, but of course it could be more, like with sexual orientation, gender identity. But for the data that is being collected but that is not presented, then there has to be a willingness, incentives for the federal government and for the states to present that data. So that's one. I'm not sure if I got the whole the question on what was that?
Sorry. I'm good at that. So with that, I know we're almost at time, and again, want to thank you so much for joining us today. And just, I think there was a question about whether the slides will be available. We will make sure when they're completely ready to go that we will be posting those so you can reference them, and hope to continue to refer to Dr. Ponce as an expert in this area, who can help provide resources. So with that, I'm going to turn it over to Monica to tell us about what's next and how do we access these workshops coming up.
Thank you so much, Carrie, and thank you all for joining us for today's plenary. As Carolina mentioned before, we have 4 workshop options for you today. If you navigate to your left-hand sidebar under main navigation, you'll see agenda, and then under agenda, you can choose which workshop you would like to join. If you encounter a waiting room, sit tight. We're just, making sure everything is set and ready to go before we let you all in. And if you have any other questions, please feel free to use the chat and reach out to CPEN staff. And don't forget, we have data office hours, very fitting today, at 12:30 after our workshop. So please do join, again, using agenda, and you'll be able to navigate to those data office hours to ask any of your questions. But thank you all so much. And please, again, you will be leaving this Zoom and this area, and you will be navigating to whichever workshop you choose for day 2 of our 3-day virtual conference. Thank you all so much.
Thank you.